Good evening, everyone. Today's class is about what will I say? Today's class is about hemangioma and also brain. There is a lot of case in today. Here you can see in lateral phase hemangioma was showing hyper, so it's look like this. Hello. Today let's start from hydrocephalus. Here you can see this is the 28-year-old patient. Here you can see the ventricle was fully dilated. The ventricle was fully dilated in this radiograph of brain axial CT. The ventricle was totally dilated. In most of the cases, the baby's brain was look like that. If you see lots of babies, यहाँ पे ऐसे दिखाई देता है कि बहुत सारा बेबी उसका जो हेड है वो ज़्यादा बड़ा रहता है, तो वो सब पेशेंट का ऐसे ब्रेन में हाइड्रोनेफ्रोसिस रहता है. मतलब जो CSF फ्लो है, देयर would the CSF flow through brain through spinal cord. In that area was block stenosis, so it's happened, or there was something more reason, but mainly this is the main reason. It's called cerebral aqueduct. I will show the cerebral aqueduct. Here you can see the ventricle was totally dilated in this patient. The ventricle was totally dilated. So if you see this type of patient, it means the ventricle was, here you can see this is not a 5 mm. I will show you the difference between the thin slice or the thick cell slice. Here you can see this is the 5 mm image of brain, and this is the 0.65 mm of the brain. Here you can see the key difference. In this patient, the ventricle look like, or the brain white matter look like so good in this image, but here you can see in this 2.5 mm image it's not that much good. It's hazy just because there was a thick slice. It's just a 0.6 mm slice, so it's not that much good, but it will be needed for 3D. If we added more slice in 3D, it's the corneal sagittal view was more good to see, just because there was a lots of details in every slice. So I will show you the in this patient the ventricle was, if you see the normal patient ventricle is not that much larger, and this is full of CSF. Hydrocephalus it's called. In brain you can see that type of CSF. Here you can see the ventriculus totally come over this area. Normal patient, it's not that much area covered in ventricle. If you have any type of query, just comment below. I will try to answer. In MRI there was a test called CSF floor study. In this patient we will need the CSF floor study just because it shows the ventricle was dilated with CSF. So we will try to find out either the CSF was properly flowing to spinal cord or not. So the CSF floor study was helped to identify there was a good enough flow of CSF or there was a stenosis, or it's showing the CSF flow study in MRI. Here you can see the CSF flow from ventricle to the spinal cord. CSF flow in this part. Here you can see the black line goes to this way. In this point it's called cerebral aqueduct. In this point it's called cerebral aqueduct. This patient shows in this area there is a stenosis. There is a thin area of this part, this duct, cerebral aqueduct. This is the area of cerebral aqueduct. I will show you the image. Here you can see in MRI it's properly viewing the duct was properly showing, just because in MRI the CSF looks bright, so it's properly showing the anatomy, whether it is the actual location of this. Here you can see this is the duct. It's called cerebral aqueduct. Or if this patient also have stenosis. Stenosis means there was a blockage of the flow. Sometime the artery or vein was blocked, so that it's called stenosis. Aqueduct stenosis. Here you can see the duct was properly blocked. I will show you normal brain image. Let me a minute. I will show you the normal MRI brain. If I have here you can see, oh, this is, yeah. In this patient I try to find out, this is a 5 mm slice of the brain. It's a 5 mm slice of the brain. So if you see, it's not properly showing the area. It's jumped the image just because this is a 5 mm slice, and we need to the thin slice to look in this duct. So I can go to the ये देखने के लिए जो थिन स्लाइस होता है वो होने से ही पता चलेगा. It's totally difficult to identify it in just because it's maybe this point of what I am showing the image. It's look like this in MRI. This last patient I show you the MRI image, but this is not actual position. Here you can see. I will show you. This is the actual position. This is the stenosis of this cerebral aqueduct. So we get back to the next topic. It's important just because if you see that type of patient, it's just because of this problem the brain was dilated. The ventricle was dilated, or it's called hydrocephalus. If you find that type of patient, just share with me in WhatsApp group. Also, you will join in the link on my channel page. It will be, I will share the link. And now this is a chronic infarct. Chronic means it seems like since ago, like this maybe week ago of the infarct happened, so that the infarct was properly visualized. Just because recent infarct was not that much dilated. In MRI, the recent infarct was properly visualized in DWI. So here you can see in this left thalamus, this area was hypo. In this application, I don't have option to 2 mm 1 mm slice to convert to the 5 mm slice. So here you can see the actual infarct is not properly visualized in this image, but so that I will also collect the 5 mm slice, just because in 5 mm we have good amount of information. We have few in 5 mm slice. So here you can see this is the infarct of the brain. It appeared hypo, and the area was properly showing in this slice. This area is called thalamus. I will just show you the information, just because every day you see this patient. Also you will scroll every image and you try to find out there is any type of information. It's not properly if you see this patient, there was a lots of information, but what is the actual problem is this. Here you can see the calcification in this area. This is the calcification, just because the calcification is more bright, similar to the bone. It will be appear sharp bright. This is the second case of today. Now I have showing yesterday there is a arterial enhancement in this triphasic abdomen. If you have any type of queries, just comment I will clarify the queries. I will try to simply explain everything. Here you can see this is the plain abdomen of a patient. It's you can scroll finely the liver. There was no any lesion or hypodense or hyperdense lesion, like there was no any cystic or abscess or tumor like lesion in plain, so it's look perfect. But we can go to the arterial phase. Here you can see the artery was fully hypo in this slice, and here you can see the enhancement of this area. It's called hemangioma. Hemangioma is a tumor, but it's non-cancerous. In arterial phase, hemangioma was showing bright, just because the hemangioma have vascularity. हेमेंजियोमा में फेशियल रहता है, तो इसीलिए जब भी कॉन्ट्रास्ट फ्लो होता है वो ब्राइट आता है, क्योंकि नॉर्मल ब्लड तो ब्लड ही दिखाई देगा, वो उतना आइडेंटिफाई नहीं होगा सीटी में. जब आर्टेरियल फेस करेंगे तब when we will do arterial phase it's appear bright. So other than that everything was normal. I am try to showing the anatomy. Here you can see this is the pancreas. Next patient about pancreas. This is the pancreas. It's normal, and here you can see this is the stomach of this patient. Also in the large intestine there was a air everywhere in this patient. Every black bubble is air in this patient, just because maybe it's the scan is taking after not afternoon maybe, or patient don't have that much drink fluid. So if there was any type of lesion in bowel, it's not identified, just because the bowel preparation is not good in this patient. Here you can see the portal phase also enhancing the area. In hemangioma you will see this type of enhancement. That's all for this patient. I will show you the planning of the patient. It will be important, but convert this. Here you can see this is a delayed scan. The kidney appears normal in this scan. If you plan a triphasic abdomen, you will be I will show you the image. If I have lots of images. Yesterday I have collected lots of images. Here you can see this is the this is the planning of a patient. So it's not good. This is the planning of a abdomen CT. Here you can see the liver in this. In the past scan, you don't identify whether the liver ends and whether the bifurcation location. So it will be show you just a idea of the area. Here you can see the liver was look like this in this area. You can see the outline of liver, just because liver tissue has more dense than any other tissue in abdomen, so it's appear little bit of bright. Also you will find out near the iliac bone, the bifurcation is start in this point. My pencil is little bit. The bifurcation is start in this point. This is the bifurcation. So when we plan the triphasic abdomen, we need to first arterial phase starting from here to the bifurcation, just because most of the important abdominal artery was ended in bifurcation. So arterial phase was include that much area only. After that we have needed portal phase for liver. Here you can see the liver was ended here, so the portal phase of area is that much, and the venous is included full area of the abdomen. So this is the planning. I'll just show you, just because I have collect the cornel locator of the patient. So this presentation, this patient will be also ended here. Next patient was also abdomen. I will show you the actual diagnosis in this patient. It's loading. Partial annular pancreas. In this patient, here you can see everything was look like normal. This is a portal phase. I want venous phase for proper enhancement of the abdominal organ. This is the venous phase of the patient. Here you can see everything looks like normal, but patient have history of vomiting, so it means there was some type of problem in this patient. Here you can see the pancreas. In this patient, pancreas was more important. I'll show you the actual. Here you can see the pancreas was like compressed the duodenum. This is the pancreas. Normally pancreas ended here and connected to the duodenum, but here you can see it's partially cover the duodenum. Some cases it's fully cover the duodenum and compress the duodenum. It appear patient feeling of vomiting just because of the duodenum was compressed by pancreas. So this is the diagnosis of this patient. Normally here you can see in this slide, normally pancreas was connected to the duodenum in this type of area, but here you can see we can scroll the image. Here you can see the pancreas was compressed the duodenum in this area. Therefore for that the duodenum was obstructed for the pancreas. It's after that it's appear it seems to present some type of problem like vomiting, nausea. So this was the case. This was the diagnosis of this patient. Now I show you a calcified granuloma. Here you can see in this patient calcified granuloma. It means this is a old infection. It's healed the infection. After that it's dissolved in calcification. So if you see that type of calcification in lung, it means the disease like TB or lots of disease, TB or similar type of disease was after dissolve, it's convert to the calcification. It's totally dissolved. After that it's convert to the calcification. So it's appear some type of shortness of breath or chest pain. So the this is the diagnosis of this patient. It appears some type of shortness of breath, SOB, shortness of breath. Here you can see one more calcification in this area. So it means there was some type of infection in 6 months or 1 year ago, or it's dissolved. So next point is about MRI fistulogram. Here you can see in this MRI image the patient have some type of movement, so it's appear jumping. I will show you the sagittal image. So here you can see the fistula was moved in this direction. When I am scrolling the image, this is the fistula, but most of the patients don't have that much big fistula. This is a larger fistula, so it's totally identified in this MRI image, but most of the patients don't have that much larger area. So this is a steer corneal image. Here you can see the fistula was started from here and it's go down to this way, and after that it will be open in this location. So lots of patients have problem in fistula. In MRI the fistula was properly identified. Lots of patients have bleeding to stool. It's appear so problematic. So in MRI it will be properly visualized whether the problem is, or if patient have that type of fistula, it's appear ये ऐसा कोई फिस्टुला होने से ये टाइम के बाद ठीक होता है और फिर से स्टार्ट होता है, क्योंकि ये एक ड्रेन है, ये एक रूट है. ये रूट से जब भी मतलब कोई सा भी कॉन्स्टिपेशन वाला फूड खाने से और ऐसा कुछ होने से यहाँ में जब इस ये मसल में जब कंप्रेशन फील होगा तो तब यहाँ से पूछ के साथ ब्लीड भी बाहर होगा. तो ये प्रॉब्लम बहुत पेशेंट का होता है. दिस टाइप ऑफ प्रॉब्लम है लॉट्स ऑफ पेशेंट हैव फेस in T2. It's not properly identified just because the fat was bright, also the collection was also bright, and I will show you little bit of the area. Here you can see the fistula area. So I will show you the planning of this fistula. A more important sequence in fistula was, first of all, we take a whole pelvis axial steer image. In this image we will cover the whole pelvis. So it starts from the iliac bone and it's end into the end of the pelvis. So in this sequence we find out if there was a lesion or whether the lesion is properly find out. So we will find out the fistula was started from here. I will show you the exact location here. The fistula was started from here to the, so that we plan the axial scan started from above of the starting point to the end of the point, or it's also we also try to perpendicular to the anal canal. We will plane the axial 90 degree of the anal canal. So I show you the axial here you can see the axial scan was started above the fistula. So when we plane accurately, the problem was appear properly. Here you can see in this area the lesion was started, the fistula was started from here. So the main sequence of the fistula is steer, corneal, sagittal or axial. Along with that, I will show you in sagittal T2 says and steer says. This is the two sequence of sagittal. So after that we have added a steer corneal. Next sequence was axial T2 T1 steer DWI. If there was a bleeding, if you see in steer there was a abscess or there was a more larger collection, so some cases we add SWI GRE sequence, gradient echo for bleed. SWI. We need SWI for bleeds. Yeah, okay. So in this sagittal image we will properly visualize the fistula. Or most of the cases the fistula was not properly visualized just because sometimes the fistula tract was so small. I will show you the. Sometimes it appears like this, so small line. Also sometimes there was a vessel in this area. Here you can see this is the blood vessel. It seems like a fistula, so it's difficult to identify. Some patient don't have any fistula, so when we give the contrast it will be appear properly. Here you can see the area of fistula was properly enhanced in this contrast study, and it's similarly follow the area to the end of the fistula tract. It will be showing enhancement just because there was a infected fluid. So this is end of this fistula session, and here also in fistula or in rectal abscess the sequence was same. We will need diffusion also. Here you can see in diffusion we found the actual problem properly, but if it is so small area it's not appear. This is the abscess, perineal abscess. Here you can see it's called abscess just because the area was there was a collection in this area. तो इसीलिए इसको पेरिनेल एब्सिस बोला जाता है कि जहाँ में जिस भी कलेक्शन में ज़्यादा से ज़्यादा फ्लूइड रहता है, इसको फ्लूइडिक कलेक्शन रहता है, उसको एब्सिस बोला जाता है. So in this patient, the abscess was fully visualized properly. Just because it's too big. Here I am showing the you can see the prostate gland, and this is the bladder. This is the sigmoid and this is the anus. So this class is ended here. If you have any type of query, just comment below. I try to answer. Thanks for watching. We'll see you in the next stream. Good night.